skip flap, please. So skip flap phalloplasty could be standard of care because this is not a free flap. This is a pedicle flap which is based on the superficial circumflex artery, a successful groin flap which is raised from the groin, and it's based on a perforator of superficial circumflex artery. Since 2005, modifications brought it to a level where initially plastic surgeons took it and then discarded it. But we are looking at a phalloplasty for these patients who are needy because of congenital deficiencies or because of transgender phenomena. We're going to look at the donor side not having a scar, and this organ should be capable, sensate, and aesthetic. When we look at that kind of a situation, we're trying to create an ideal neophallus. This possibly could be a way for future. We at Coquelin Hospital have completed 19 such cases and evolved into a technique modifying ourselves, where in gender reassignment we do a psychiatric endocrine workup and do technical considerations, because skip part phalloplasty is a 3-stage process. The phallus is first stage. When it matures, gets a urethra, and finally the penile process is a single process by my senior colleague and Dr. Shah. The technique that we show is basically getting a true gender affirmation of biologically deficient males. Out here, it's a 23-year-old male who presents with micropenis which doesn't grow. Because it's a pedicle flap, preoperative Doppler, on-the-table Doppler is of paramount importance to identify this important perforator. We learned this technique from our plastic surgery colleagues who didn't find this so interesting. But when we look at deficient males and male to female gender reassignment of a pedicle flap where you don't need a microvascular anastomosis, you get this groin flap 18 into 10 centimeter. I gather more than 15 centimeters would be a loss, or there will be loss of blood supply with the perforator. We've learned from our own mistakes and technique deficiencies. So the flap is being lifted up to the level of deep fascia, lateral to medial, because we have to medially transpose it and bring it underneath a segment. Out there, that's a vessel marked vertically, which is the skip vessel, and that perforator is what needs to be identified. So you're going to go on the medial aspect of the thigh or the upper part, so that entire groin area is being opened up in 18 to 10 centimeter. That's the time I would use a loop 3.5 to identify the perforator which is coming into the view, and we'll look at dissecting it very closely with as a thermal as possible. We look forward to keeping the pedicle as long as possible so it does not get twisted, looking at removing as much fat from there, so it decrease the size of the flap, number one, and number two, to decrease the twist and the edema on the pedicle, which will be a long pedicle that will be going all the way to the phallus. A very strategic location will be identified of it. Actually, if it's a micropenis, just dorsal to the micropenis, and if it is a patient who is a gender reassignment, then it's at the pubic symphysis for the location of a neophallus. The perforator and the dissection of perforator again is a crucial step, and the procedure is slowed down gradually. We may take coffee breaks in between, allow the spasm to go away, and come back again and redissect and look at it. That's where that's a micropenis, or if it had been on a female clitoris, we do an incision, which is a curvilinear incision, and dissect it all the way down till the level of the pubic symphysis. That means we have the bone waiting there. So that dissection is then to create a finger tunnel from where we will transpose this flap and bring it medially. So lateral to medial movement will a lot be depending on the kind of dissection and the kind of secondary perforator branches which we'll have to dissect out. So that's the way we transpose this long 18 into 10 centimeter phallus, and we keep watching the blood supply all the time. Out of the 4 people scrubbed up, 1 person only watches the blood supply and looks at the bleeding, while anybody else continues the anatomical technical dissection work. So that's being brought down medially. Skip flap has been a part of plastic surgery folklore, but they've given it up completely in plastic surgery. We then lengthen up, like we lengthen any pedicle, we lengthen the pedicle and look at that. Extra skin would be removed, but the tissue inside would be left because otherwise the blood supply will go away. So we dissect it to a level, debulk to prevent tension, continue debulking as we close. The suture line for this phalloplasty will be ventrally in the midline. This is to help me for future urethroplasty, where I'll bring the urethra, tunnel it. It will be a scrotal flap tube, or it could be a labial tube, as it could be a male or a female. But right now we are going in for a closure. And this closure is a very dedicated closure. Interrupted sutures, which sometimes could be left very loose to prevent any edema fluid not collecting inside. Debulking is a gradual process to prevent any blood supply loss. Remember, it's a perforator with its branches going to the cutaneous zone. So debulking done very gradually as we continue closure of this. We've had our trouble in such cases too. There are times we have to run down the entire anastomosis and wait for the whole spasm to go away. So this is a ventral midline suture, and this can't be open for a urethroplasty. You have to tunnel the urethra underneath this 3 months or 6 months later as required. So interrupted closure, leaving some sutures so that the wet areas or edema fluid can soak out, because this will be dressed in a vertical position. we would be then creating, this closure on the donor area is very important. So donor area finally is a single straight line rather than the massive scars of radial forearm flap and abdominal flaps. So that will be a single line. The patient actually will be kept in a semi-flexed position for 48 to 72 hours so it doesn't stretch it. So while we close the donor area, the technical phalloplasty area is being closed gradually. We're inverting the tip to create the tip of urethra, which will be little on carved on to give a future gland. So that's the ventral suture line which would heal. This patient would then get a scrotal flap if he is a case of male, or it will be labial flap if it's a female to male phalloplasty. And the donor site is a single scar line. The nursing of these is very closely guarded, and this is always in a vertical position. No compression dressings out here. We watch it very closely. The first 3 days the patient is on the bed. Why skip at all? Skip as a perforator-based flap. You don't have to do a microvascular anastomosis. These are long surgeries. We know that other surgeries have actually stood tall. When we look at the donor side, we look at the recovery, we look at the morbidity that we create out of this compared to what we have in the past. I think this has actually stood very tall. We're into 24th case right now. Feels good that we have had a fair say on what we could get. So we could get a flap elevation time being short. We could customize an adipocal flap. Dominant perforator always stays, which is being watched post-operatively. We look at the Dopplers post-op. Very minimal morbidity in this. Sensation, yes, a great question. If you would ask, sensation is only till the 2/3 of the shaft. The tip does not have sensation at this point in time. So compared to all the flaps that we know on the free radial forearm flap in microvascular anastomosis, we know urethral fistulae, donor side, massive morbidity, and the kind of situation which goes through in that, which has been raised as gold standard. This has got a minimal donor side morbidity, no microvascular anastomosis, and therefore we advocate this as possibility for the future. But we have had our own trouble around. I attempted somebody on request a long length, and I could not get that. If I gave them, we had a tip necrosed, or we have got our own lumpy, bumpy ways of creating this mess. This is really a challenge. It's only a journey that we are in, and as more colleagues get into this business, we need to realize a dream for needy individuals who possibly cannot perform sex because the penis is really a micropenis or amputated shafts, and they are very young. Or the females to males who get through many surgeries, and finally this surgery could be his future. Thank you so much.